and sequencing and analyze mutation of filaggrin at the University of Edinburgh with Sarah Brown. She have a talk about it at the end of this session. We want to compare European, Japanese, and Afro-American study to Malagasy study. But we have a big problem to send sample to England. After 6 months, we have no result till now. The first result so that we don't have a gene mutation using this site. In 30 cases, no detection of mutations. It's few, but you need to have the sequencing for with the study with Sarah Brown in genetic using sequence and immunohistochemie. If you report to WHO data, 80% of skin problem in Africa grouped in 5 pathologies: atopic dermatitis, tinea, scabies, and impetigo, and insect bite. And you think that using artificial intelligence is better tool to collect data, because we train many countries, in Africa only Madagascar, Tanzania, and Guinea, and we have America, North America, and Switzerland, Australia, India, and Chinese. And we have six collection sites in Antananarivo, in Mahjong, and in Toléar with Antirabe for the collect data using computers and digital camera only. No more device. And here, to have a best resolution in black skin, we paint all the room in green. And we establish this ape mycelephone with Malagasy specialist in IT, with the data and skin phototypes like in Malagasy, with the hair, with the color of the body, and in Bâle, the founder Botnar and Fondation Botnar, and Ibrahima Traoré from Guinea. The preliminary results show that in 482 cases, atopic dermatitis have a big plus because it's the first in this, 144, tinea 143, scabies 139, and impetigo and insect bite. We have a trend, but I have no time to explain you, but we have a trend in atopic dermatitis because the precision and recall is not different. And at our lab, Dr. Herzo is there, we implement a study with informatics to do all this study here in Madagascar. Before they sent to India and China, but now we have all of the people who can work in this. HOP is during the 75 World Health Assembly in Geneva. There, the Global Dermatology Coalition launched to improve health outcome for people living with dermatology disease worldwide, because you see, tomorrow, when you have a chronic disease in dermatology, it's very difficult because you have no more treatment and no experience and no hope. And this is very important because we include in this global dermatology coalition, we have laboratory, industry, scientific researcher, dermatologists, and patient associations. We think that with this association, we can work in all of the why we need to know in barrier defect in atopic dermatitis. That is the way that we think that genetic study of filaggrin deficiency might highlight the knowledge of atopic dermatitis in black skin. They know data till now. It's the first study. We have a little bit study in Ethiopia, but done by someone from Europe, and Peter have a work with Tanzania, but work from South, it's the first. AE is the best solution to reduce the distance, to solve lack of dermatologists, to help healthcare. And for the developing training and monitoring AD, 2 districts medical center, we can use our experience in HIV electronic platform with our team who manage this disease. And you can use the field mission in chromoblastomycosis and sporotrichosis in endemic area to collect the data for atopic dermatitis. And this is a map, a photo I take in the field. You know, all of the children you see have a dry skin. That is a big problem, but it's not known. Thank you. Thank you for someone, member of ISAD who need to go to Madagascar. You are welcome. Thank you. On behalf of my staff, thank you. Thank you.
Thank you, Benja. Very nice insight and very nice research you are performing. Vous avez des questions pour Professeur Raplanaro?
We were discussing with Peter during your presentation, Benja. What is your guess for the study on filagrine? Because what about the genetic constitution of the Malagasy population versus first Africa, second Asia, and Europe and the Western world? So could you guess to find, for example, some Asian mutations that are not present in previous studies in Africa?
No, it's difficult to answer it because we have many. Till now, if you ask the history, they are difficult why to explain Malagasy genetics, and I think it's a study we need to do because last study in Malagasy genetics shows that many cases came from East Africa for women and Asia for men.
Oh, really?
It's very difficult to explain, and it's a study done at the University of Toulouse with Malagasy. And I think I don't have the result, but we can compare to this.
Any more questions or comments?
Maybe a comment from Ali, you know.
Thank you so much, Benja, for the interesting presentation. To my side, I think we have the same spectrum of atopic dermatitis. My institution, which is Derm Hospital, we have about 15,000 outpatients per year. And regarding the prevalence, I mean, the frequency of atopic dermatitis, it's about 10%. In children from 0 to 15 years old. The common complication of atopic dermatitis is a supper infection. In addition, most of children suffering from atopic dermatitis has also lichenification, which is a very common presentation indicating that patients are really suffering from pruritus, from itching. In addition, about the treatment, the main treatment we have has shown by the roadmap of ISAT is steroid ointment and emollient. We do not have targeted therapy or immunosuppressive treatment. Sometimes we have cyclosporine and what else? So, about the genetic, we didn't start any study. We don't have any idea. But by the way, of the genetics of Malagasy populations, I don't know whether there is a link with Asia, as already pointed out by Professor Alenta. It will be very interesting, because what we know is follicular mutation doesn't exist in African descent. So thank you so much.
Yes, you know, one of the problems is if you see the traditional use in the east, in the coast of Madagascar, it's like in Asia. But the Malagasy face in the center is like in Asia too. It's different. And that is why it's very difficult to say that it's come from. But a large study, genetic study, in large populations is needed, I think.
Can you later on correlate, let's say, the face of the patient with the genetic results? So the more Asian-looking one with the more African-looking one?
If you do sample in the center, we have a face like in Asia, and in the coast like in Africa. But as I told you, the traditional, after the traditional and the habits in this is different. The habits in the coast is like in Asia, and the habits in the center is like in Africa.
It will be very interesting. Yeah.
Another question that come to my idea is about the cytokine profiles in Malagasy population, because I read some paper stressing about the cytokine profile that pointed out in black Africans the cytokine profile is different from Caucasian and from Asian. Do you have any idea about the cytokine profile in Malagasy population?
I don't have. Maybe, Ahmad, you can help me? I don't.
Yeah, we can come back later. I will talk on that topic in my lecture. But please, Professor Ball.
Yes, please one question. I remember when we were in Geneva, I saw this clinical presentation from Professor Peter Schmidt about this popular lesion. Do you see this type of clinical manifestation in Madagascar? Because I don't have the same impression in Mauritania. I don't know if you see it here in this region.
Here, I don't show all of the clinical presentations, but I can. You see it. You see it. We have many cases that is not shown in another country, but you collect it now. With Dr. Van der Seen, we collect it now to publish this a specific mode of presentations.
So thanks a lot, Dr. Raplanaro. Before we call Dr. Sendrosa to the stage, she will speak on the quality of life in adult patients with atopic dermatitis. Oh, in children. Oh, sorry. Yeah. In the meantime, I would like to ask the audience, who of you sees patients with atopic dermatitis? Okay, so it's really something you need some background science to this important disease. So you will see how much it affects also quality of life. Dr. Sendrosa, please.
Thank you for giving me the floor. It's a pleasure for the dermatology team from Madagascar to present you one study who assessed the quality of life in children with atopic dermatitis seen in the Department of Dermatology, University Hospital, Antananarivo. We will follow this plan as introduction. As atopic dermatitis, we know that it is a chronic dermatosis, inflammatory dermatosis, which is characterized mainly by pruritus, and due to the increased prevalence of atopic dermatitis in children in the last years in Madagascar, and no data concerning the quality of life in Malagasy children with atopic dermatitis was made. So we made this study. So we aim to assess the quality of life of Malagasy children with atopic dermatitis. So a cross-sectional study was conducted in the Department of Dermatology at the University Hospital Antananarivo from January to December 2020. Children with atopic dermatitis less than 16 years were included in this study, and different questionnaires were used to assess the quality of life. The EDQOL for infants up to 4-year-olds, and the Children Dermatosis Life Quality Index for children between 4 to 16 years old. The Dermatitis Family Impact Questionnaire was used to assess the family's quality of life. As a result, 62 atopic dermatitis cases were included, and 41 were infants less than 4-year-old, and 21 were children between 4 to 16-year-old, and there are female predominance. The severity of atopic dermatitis was assessed using the SCORAD, and the mean SCORAD of patients were 40, and 38 patients present moderate form of atopic dermatitis. The mean score of IDQOL for infants at the first visit were 11.3, and there are no improvement of quality of life of children after treatment. However, in children between 4 to 16-year-old, there are improvement of quality of life after treatment. Concerning the family's quality of life, the mean score of DFI were 10.6, and we show that most of families presented moderate and important impact in their family, in their quality of life. Analytical studies show no correlation between quality of life and socio-demographic variables. However, significant correlation between quality of life and the severity of atopic dermatitis was found. More atopic dermatitis were severe, more the impact in the quality of life in infants and children were important. And the same result is found: more atopic dermatitis was severe, more the impact in the family's quality of life was important. If there are the results, what we can discuss compared to other studies, the quality of life in infants found in our study show that the quality of life of infants is more impaired in our study, and our result is similar to that found in South Korea, and the similar finding is shown in children, and our result is similar to that reported in Singapore. Concerning the family's quality of life, different scores were found depending on the country. And concerning the quality of life and socio-demographics, several authors reported positive correlation between gender, age, and the quality of life. However, our study found no correlation between gender, age, and quality of life, like studies made in Algeria and Singapore. The high correlation between severity of atopic dermatitis and quality of life are also common in several studies, like in our study. And concerning the family's quality of life, the positive correlation between family's quality of life and severity of atopic dermatitis was also reported by several previous studies. And our studies show that family's quality of life is more impaired for children who are more dependent on their parents. So our study highlighted that atopic dermatitis impairs the quality of life of children and infants. More atopic dermatitis was severe, more the effect in their quality of life was important. And our studies show also the improvement of quality of life in children under 4 years compared to baseline. And correlation between children quality of life and family quality of life. That's the end of my presentation. Thank you for your attention. I would like to thank also the International Society of Atopic Dermatitis for their support for research project, especially in genetic study in atopic dermatitis.
Please stay, Dr. Sandrosa. Maybe there might be questions for you. I don't know if anyone from the audience. Yeah, again, Professor Fayere.
So thank you so much for this nice presentation. We did a multi-center study about atopic dermatitis, the score of atopic dermatitis and patient-oriented score of atopic dermatitis. We also found that there is a strong correlation between the severity and the score of atopic dermatitis. So what we also found was most of the cases we came to us are moderate cases of atopic dermatitis. So I would like to ask you, in your study, did we experience a patient, because since atopic dermatitis is a very chronic condition, did we experience a patient or family we first go to traditional healers or, I don't know, alternative medicine before coming to us? Or ever, do you experience patient who ever use alternative therapy and herbal therapy plus modern medicine? So I would like to have your experience.
Yes, thank you for the presentation. It's the same vein. In Madagascar, do the patients accept to have a chronic disease? How do they cope with a chronic disease? Thank you.
Donc, for the first question, Malagasy people use herbal medicine, traditional medicine, and use different sort of wall. There are many herbal wall. They use it, and before going to dermatologist also, they go to general practitioners, to pediatricians, and they receive corticosteroids or over treatment, and we see patients moderate or severe stage.
So how important is pruritus in your patients? Did you assess pruritus like using analgesic visual evaluation or something like that? How important is pruritus in your? How frequent is it? It is.
Yes, we use an visual scale for assessing pruritus.
Et c'est fréquent que le prurite comme symptôme chez vos patients, le prurite, c'est fréquent?
Oui, c'est fréquent, c'est constant.
Just, I had a question concerning your results. There is one group with no clear benefit on quality of life after therapeutic intervention. I think the older age group, no?
All the two groups?
Yes.
but only we evaluate infants and children who return in follow-up.
Yes.
Donc there are some patients who are dropped out.
Yes, but for the patient you could evaluate, there is a difference between the two age groups. Okay, that's your conclusion. So how do you explain this point? Is it that according to age, the compliance with treatment is not the same, or any other kind of explanation?
Maybe the explanation for infants, we don't find improvement of quality of life after treatment. Maybe there are a few infants who return in follow-up, so there are bias for result. But because Malagasy, when their lesion improve, they don't return in the dermatologist. So we only see someone who have their lesion who worsen.
I found your data very interesting as it was done in children. Just as a comment, we've done similar investigation in adult patients, more than 1,000, and there we see also quality of life is depending on severity, but there you see women suffer more than men, and if the face is affected, this is sometimes more important than the whole rest of the body. Maybe in children it's different, and I think boys and girls are not so sad, but later on we could see clear differences in adults. So it's very interesting to compare also the two age groups. Okay, there's more questions?
Yeah, congratulations, Center for the presentation. My question is about items that you assessed during the study, because you used many scores of quality of life, but because we know we are not dermatologists, so can you give some details about items that you assessed? Thank you.
For IDQL and CDRK, there are 10 questions, 10 items to assess, so that assess the symptom, the pruritus, and they assess the impact of the disease on the hobbies, on the clothes, on the personal relationship, and also the impact of the use of medicaments, of drugs, in their quality of life. So we can resume.
Any more questions? D'autres questions? Oui. The next one is Dr. Ratsana Korto, who will speak about adhesion to treatments in atopic dermatitis. I hope I gave them, and I think she has earned an applause, and in addition could make it in English. Thank you very much.
Thank you for the floor. So we are glad to share with you the results of our study about treatment adherence in Malagasy patients with atopic dermatitis. This is the summary of our presentation. As we know, atopic dermatitis is a chronic inflammatory skin disorder characterized by intense pruritus and dry skin lesions. It appears early in the childhood, but it can appear in any age. its prevalence is still increasing in sub-Saharan Africa, and in Madagascar, this prevalence range from 1 to 5% in 20 years. The WHO in 2003 estimated a mean adherence rate of 50% among patients with chronic diseases. And in a study done at Madagascar in 2016, they found an overall compliance rate of 35% among patients with chronic dermatology disease. And we know that non-adherence to treatment in dermatology leads to treatment failure and poor clinical outcomes. So we aimed to assess treatment adherence in Malagasy patients with atopic dermatitis, and secondly, to identify factors that influence this treatment adherence. So we carried a prospective analytical cross-sectional study done in the two departments of dermatology at the University Hospital of Bethesda National of Madagascar over a period of 12 months. Patient data were collected on an individual survey sheet. We included all patients with AD whose contact details were available, who consented to the study, whose answers to our survey were accurate. Were not included patients who was seen just one time, so with no follow-up. And we excluded patients with unclear answers to our survey. We use more risky medication adherence scale with 8 items to assess patients' treatment adherence. Variables studied are socio-demographic characteristic, clinical and therapeutical parameters were studied. All statistical analysis was performed by IBM SPSS version 20, and we use Fisher-Exact and regressions test for compare all the parameters with the adherence levels. So, in the beginning, we included 71 patients, then 6 patients were excluded. So, finally, we enrolled 65 patients. The socio-demographic characteristics are summarized in this table. We have a preponderance of male people in children and female in adults group. The mean of age was 4.29 in children and 35.28 in adults. Not graduated people, graduated from high school, was preponderant. Married people was more than unmarried people. Employed people were more than unemployed people. And people with mild monthly income was preponderant. Most of our patients didn't have sort of insurance coverage for medical fees. In adult patients, most of our patients are non-alcoholic and non-smoking. For follow-up, most of our patients were seen for follow-up more than once in a half year. According to the SCORAD, moderate form of atopic dermatitis was seen in more than 70% in children and 60% in adults. All of our patients receive topical medications. None of them receive specific oral medication. Were used corticosteroids, emollients, and none of our patients receive a topical calcineurin inhibitor. Most of our patients experience drug effectiveness, and none of our patients experience drug adverse events. Most of our patients were satisfied with treatment, and according to the MMAS score, we found in children a score of 5.9, and in adults a score of 2.5. So in this study we found that low adherence is preponderant in our both groups. For assessing correlation, we didn't find a significant correlation with adherence levels and all of the socio-demographic parameters in children, and nor with clinical parameters and adherence level, nor between therapeutical parameters and adherence levels in the children. In adults group, we find significant correlation between age with a p-value of 0.0003. So younger age is associated with low adherence rate. We found also significant correlation between educational status and adherence levels, as we see at the slide, and a significant correlation with marital status and the adherence levels. So in our patients, married people were in higher risk to be non-adherent. We didn't find the correlation with the rest of all of the parameters as seen before. So the strengths of our studies, it is the first study about treatment adherence in AD. In Madagascar people, maybe in Africa. And a second strength is that during the study, individual interviews helped already to strengthening therapeutic patient education and strengthening patient-doctor relationship, which is already a way to improve adherence. However, our study were limited by sample size due to the pandemic of COVID during the period of study. So all the activities of two departments were restricted. So we got a small sample, small size of sample. The tools used to assess adherence treatment in our patients is an indirect measure. So it's subjective, it's self-reported, and it could be a bias for our study. And in our study, we couldn't compare topical and versus oral medication adherence because our patient didn't receive specific oral medication. So adherence, the term of adherence is differ to the term compliance. Adherence implies a treatment relationship that in which treatment is discussed between clinician and patients, and after finally prescribed after a mutual agreement of both people. So it is a little bit different than compliance. Compliance is just the patient is just passive recipients for follow direction from a healthcare provider. Measuring adherence, there are two types of tools for measuring adherence. There are objective and subjective tools. This is a list of some objective tools used to assess adherence to treatment. This is a subjective tools to assess adherence to treatment, and we used the Morrissey medication adherence scale with 8 items for this study. This is the questionnaire in the Morrissey medication adherence scales with 8 items, and according to this questionnaire, there are low adherence if score is less than 6, medium adherence if the score is between 6 and less than 8, and high adherence if the score is equal to 8. Some study over the world found poor adherence to topical medications in atopic dermatitis, so it is consistent with our results. In this Japanese study, they found a correlation between gender and adherence to topical medication. A correlation between employment status and the frequency of hospital visits. In our study, we found correlation between marital status and adherence levels, between age and adherence levels, and educational status. So our results suggest a need to improve adherence. So there are many strategies described in the literature, but educational intervention, Atopic School is an interdisciplinary program that explains to patients or parents of children suffering from AD the causes, the pathogenesis, and the aggravating factor, and importantly, the way to use properly the therapy. There is some technological intervention that we could use here, like text messaging reminder, applications tools that reminder to patients to take their medicines. In order to improve this adherence, as developed before by the Professor Pelanouf. There is actually a current study about filaggrin mutation in Malagasy with atopic dermatitis, which proposes identify specificity of the gene of atopic dermatitis in Malagasy, which could be helpful for improve adherence to treatment later. So, treatment adherence in Malagasy patients with atopic dermatitis is still poor to topical medication, and in our study we found that younger age, low educational status, and the fact of being married were factors associated with low adherence. So our results suggest the need of a nationwide, multicentric study about adherence in AD, and a study about intervention to improve adherence is needed also. So that concludes my presentation. Thank you for your attention.
Merci beaucoup, Dr. Rasanakoto. Very interesting findings. Something what is quite irritating is that married people have a lower adherence than unmarried. Do you have any explanation for that?
Maybe Madagascar is a developed country, so male people. Because when we adjust with gender, we found that male people married are in a higher risk of low adherence. So male people in Malagasy household is the pillar of the family. They have to think about feeding and in the needs of their family. So maybe that situation that situation could be explained that because the cost of there is a cost of medication and
might be that they need more the money instead of using drugs. That's maybe an explanation. Any questions?
Yes, thank you. Do you have an idea about the adherence in treatment for AD compared to the adherence in treatment for other chronic disease? I came back to my previous question because I remember, I have the impression, I don't know, Professor Tai will correct me if I am wrong. In France, they accept that they have a chronic disease quite easily. Anyway, more easily than in South Africa, Sub-Saharan Africa. In my country, je vais te parler un peu en français, quand les gens ont une maladie chronique, ils ont le sentiment qu'ils n'ont pas trouvé le bon thérapeute. Si on trouve le bon thérapeute, on doit guérir. Et les thérapeutes traditionnels jouent le jeu très bien. Parfois, ils vous disent, je ne peux pas vous guérir, mais vous devez aller plus loin, au nord ou au sud, vous trouverez quelqu'un qui vous guérira. Donc, les gens n'acceptent pas qu'ils ont une maladie chronique. Et c'est très très difficile donc qu'ils adhèrent au traitement de façon permanente. Au bout de quelques temps, quand ça ne marche pas, quand ils ne guérissent pas définitivement, ils laissent tomber. Quelle est la situation ici à Madagascar? Est-ce que les gens acceptent ou n'acceptent pas?
Je peux répondre en français. Pour la première question, déjà, jusqu'à maintenant, nous n'avons pas encore une idée sur l'adhésion au traitement de la dermatite atopique comparée à une autre étude, notre pathologie chronique. Justement, il y a des études en cours concernant les adhésions au traitement sur les psoriasis ou l'acné, mais c'est encore en cours. Donc, pour l'instant, à ma connaissance, on n'a pas encore des idées sur contre l'adhésion au cours de la dermatite atopique et les autres pathologies chroniques, dermatologiques. pour la dernière. C'était une question ou une remarque. Justement, les Malgaches, les Malagasy, excusez-moi, n'acceptent pas trop le fait d'avoir une maladie chronique, en fait. Ça, c'est vu par expérience. Il n'y a pas encore d'études qui le disent, mais en consultation, on voit les patients et on sent qu'il y a un certain rejet, on va dire. Ils n'acceptent pas trop leur situation. C'est pour ça l'importance de l'éducation thérapeutique est prônée à chaque consultation, en fait. Oui, j'espère que ça a répondu aux questions.
Merci pour votre présentation. Thank you very much. Just one comment about the methodology concerning this questionnaire versus more objective assessment of adherence. I think it would be, I don't say that it is possible, but it is at least some confirmation of your finding if you combine this quite subjective assessment by the questionnaire to something more objective, like asking that we are doing in most clinics, how much you have used in your tube of topical steroids, how much have you use of emollients, if they can buy, of course, emollients, and this, even if it is semi-quantitative, if you ask even several times the question, you may have some idea of if there is some adherence or not. And I think this is, I would say, for the colleagues in the room, I think more important in terms of daily practice for a clinic about atopic dermatitis, because under treatment is really the major problem in atopic dermatitis.
I can only confirm what you write as a challenge to encourage patients to adhere all over the world is a problem, and under treatment with emollients, everything, it's really a problem. So go on with that, work on it. Maybe one question would also be whether there are differences between the, let's say, the two populations, the more Asian, the more African one, whether the adherence is different. But of course, you need more data, but go on, that's an important aspect for AD. Il y a d'autres? What?
So just a small, a very little bit comments and one question. I saw in your statistic there is one odd ratio which is very high. I mean, that's maybe the number of people enrolled is very small, I did in your speech. So I would like to encourage to keep on enrolling a patient so that to have more data, and also to include, as already stated by Professor Alantaib, to combine with objective assessment tool like to weigh the contents of the tube used by the patient, because we also did the same assessment in a study with Dexiril, which has been tested in several countries in West Africa. We pointed out that initially, patients, where we give them the treatment, they use it really, but when they saw improvement, they use less. Indicating that the improvement is also related to the quantity of the use of cream. So I have just a question. What do think your patients about injection? Because in our country, like in Black Africans, they came to the clinics and we present them a cream to put up on the skin. They sometimes ask the doctor to have an injection, because in their mind, they think that injection would be much better than a ointment. What's your point of view?
Thank you. It is same as you see. Malagasy people is like, I think it's particularly of African people, I don't know, but when they come to see you for consultation, they think that injection is fast and for outcomes, for better outcomes. So I think it's the same as you see.
I don't see more questions. Then once again, merci beaucoup. Thanks a lot, Dr. Asena Koto.
I congratulate Harmzar he worked in the northwest since 2020. He started to work there only here, the dermatologist in this region, and he tried to develop a study. Thank you, Sandra. It's very, very important to do this because he's not alone, but he worked hard. We have many, many things to do. Thank you, Sandra.
Yeah, full respect for what you've done. And if we give you advice, it's not that, it's just to improve your work, which is so important. Now it's my special pleasure to introduce Professor Ala Tayeb. He's a very experienced dermatologist, pediatric dermatologist, and he's the president of the International Society of Atopic Dermatitis with a long-standing experience in clinical aspects, but also research. Today he will talk about diagnostic pitfalls. So to give you some hints, not to confound AD, how to recognize AD, and I think we have one of the world's best speakers for that topic. Please, Alain.
Thanks, Peter. I would like also to thank the hospitality here in Madagascar, Professor Benja Raplanoro and all his team. And we are very pleased as the International Society of Atopic Dermatitis to be able to come to your country and to have this kind of mixed aspect, combining local experience and maybe more international outlook for this disease, and also to have time to discuss the major issues of access to drugs, as we did yesterday, and better training for the population in contact with patients with common skin disease, not only neglected tropical disease in the African continent. So I will review, because I think most of the audience, you are not dermatologists, maybe going back to basics and a review. So I think you have already seen this introduction slide. So we are dealing with a very common disease, more common in children. I cite this prevalence of 20% in some countries. It goes up to 25, even more. There is the idea that it was not so much a disease of adults, but it has changed over time, also because of the interest of big pharma with biologics. And what is important is the chronicity in a subset of cases. And this is why we already had so many questions about how to persuade the patients that they need a chronic treatment and a chronic management by doctors and specialized departments. So what has been also known from the pathophysiologic studies and therapeutic studies is that what we here. Where is the? I was looking for the arrow or the pointer. No. I just wanted to discuss just a bit Th2 inflammation. The dot, yes. I don't know where is this dot. It doesn't matter. So maybe Professor Wallenberg will return to this point, but it has changed a bit our life, at least in the clinics in Europe and other developed countries, to access the medications which block Th2 inflammation with the clear point that they show efficacy and quite a good tolerance. And this has changed not only the field of atopic dermatitis, but also related conditions, especially nasal polyposis and asthma, for example. So pruritus is the major symptom, and you will see in the differentials concerning possible mistakes in diagnosis that this is really the main point to consider when you have a patient where you can consider atopic dermatitis versus other disorders. And what is also very typical in this disease is this course with flares and remission, sometimes with treatment, sometimes without treatment, according, for example, to climate. We know that with UV in the summer, the skin barrier improves, and in general, most of the patients are doing better in summertime. And of course, there are also hints in terms of science on how you can recognize by pattern this disease. And of course, the pattern of atopic dermatitis, whatever the age, is a good indicator, giving you the idea this more atopic dermatitis rather than other disorder. So this is to show the chronicity. So the chronicity, the same patient I've seen, even when I retired from our department, he was still followed in the department. And he was, in fact, a good patient also to test some treatments, because he was a severe patient. I think he was on one of our first patients to receive cyclosporine. He had a good response, and he was on one of the first also adult patients I treated with methotrexate, and he had an excellent response to methotrexate. And also to point out that when I started my activity with the adults, because I am a pediatric dermatologist, but mid-career I switched to become the head of dermatology in my city, in my university hospital, and I saw adults. And when I saw first adult and sometimes elderly patients, when I thought maybe they had atopic dermatitis, my colleagues said, well, he's completely crazy, because it doesn't exist at all in this category of patient. And I just want to show you this patient. She was at the time of the photograph 91 years old. I would say I will not detail this part because it's more complicated, of course. It is like elimination diagnosis in many adult patients, because of course when you have an erythrodermic patient, a bit like this lady, you may find some T-cell lymphoma, mycosis fungoides, or a list of other diagnoses, and in most cases you will go to skin biopsy. But for the most patients with atopic dermatitis, for the rest of the disorder we will see, in general we don't need to make a skin biopsy. And the other photograph is just a baby who came to the clinic with it was not normal. We were discussing normal with colleagues from WHO, but it was severe cachexia, which can lead, of course, to, because of malnutrition, to other diseases. And this patient had some mild, moderate atopic dermatitis, but the parents were extremists, and they put this young baby on extreme diet, and this is one of the dangers, of course, of the poor management of the atopic dermatitis when you don't trust anything in dermatology. So you choose extreme measures for diet, and it could lead to cachexia, like in this patient. So fortunately, he was treated and he recovered. But the parents were very difficult to change in their vision of the disease. So looking to the manifestation, so there are some pitfalls already, some difficulties in diagnosis in very young children, because we have not so strong criteria for diagnosis of atopic dermatitis in infants. I think the criteria which are adapted from the criteria of Halpin and Rashka and the UK criteria are difficult to apply before the age of 2 years. And there are some borderline conditions like seborrheic dermatitis. And sometimes you may see the change in pattern from seborrheic dermatitis to typical atopic dermatitis. So the two are probably not completely separated, but if you see a cradle cap pattern with very minor symptoms, it rather maybe if it is a 6 months or 3 months old baby, something rather at seborrheic dermatitis and not very atopic dermatitis. And of course, if you have pruritus, generally you think it is more atopic dermatitis, because most patients with seborrheic dermatitis only, they are more like psoriasis patients with less pruritus or no pruritus. So also what is also sometimes difficult if the lesions are predominantly nummular, just looking like coins. It's nummular dermatitis, and this could be maybe more difficult in terms of diagnosis. But the typical presentation in infants is this one, the lesions which spare the medial aspect of the face and involvement of convexities, and this is the typical aspect in less than 2 years children. Sometimes you can, of course, even if psoriasis is less common than atopic dermatitis, you may, we'll show you some other slides, discuss psoriasis, because it is so well separated from normal skin. We say usually when we have eczema, it is ill-defined, the border between the lesion of eczema and the rest of the skin. And sometimes it's difficult to say, but this presentation of nummular and sometimes with, this is probably this one. Oh yes, I was here. I was on the wrong side. When you see nipple eczema, this is an excellent sign that it is atopic dermatitis. Sometimes it is asymmetric. Just one nipple is involved. So, and one of the difficulties also is to separate what is just a flare with oozing, which is quite common in children, especially in infants versus adults, to true super infection, because we know if we sample these children, they have Staphylococcus aureus all over the skin, and you'll find, for sure, Staphylococci on the skin, but in general, it is not it is healing quite faster if you use topical steroid than just using anti-staphylococci ointment. So making a diagnosis of superinfection is sometimes quite difficult. So I know that many colleagues are using either topical antiseptics or topical antibiotics in this case, or oral antibiotics. But in general, when you compare the two options, going directly to topical steroids or making a mix, there is not such a big difference. So when you have more aged children, so generally you see this pattern of lichenification, which means the thickening of the epidermis. So, and this is of course the sign of severe pruritus, and even more severe night pruritus, which means that there is difficulties to have normal sleep, which may of course induce some difficulty in behavior of the child, and of course when he goes to school to have a good school performance. And what is also very typical here is the flexural aspect at this age, after this convexities, extensor aspects in infants, you move to this more flexural aspect, and this is absolutely typical of the disease in terms of pattern diagnosis. So you have this phone diagnosis of atopic dermatitis with the distribution of the lesions. And what is noted, especially by colleagues working in Africa, is that this reverse pattern or extensor pattern is probably more common in black African skin than it is on white skin. You see, but this typical flexural involvement could be more difficult to see. You have to check precisely to see that it is, for example, in this patient here, you see it's a very minimal involvement. Here also very minimal involvement. And also, even if you can go to even milder aspects like pityriasis alba, so we call this dartre in French. It is very also common, and this is just a minor stigma of atopic dermatitis. But the same patient may, of course, have in winter time more severe flexural involvement. And facial involvement also in this age group is also quite common, maybe less pronounced than in the infants. So you see you move to adolescents and adults, and this facial involvement, and especially with this Denny Morgan fold, is a good clinical criteria. And what is also the Hertog sign, so the lack of the distal part of the eyebrow. This patient shared also, I remember, vitiligo. Association of vitiligo and atopic dermatitis was something which was completely ignored until we looked at this in our department. So one of the problems, if the disease is more localized, is to know if it is only atopic dermatitis or if it is something else. It's one of the problems of hand dermatitis, and now it is also a problem because with our studies, for example, looking at dupilumab, because some patients with just chronic hand dermatitis with not other criteria are probably atopic, and some respond to dupilumab. So on the left here is a typical case of atopic dermatitis with dry skin, and you see, if you reverse to see the palm of the patient, you see hyperlinearity, which is the meaning of associated ichthyosis vulgaris. And this one is less specific, it's Pompolix. It could be contact dermatitis, the one on the right. And some particular minor signs and presentations. So we have seen, especially discussing with colleagues from Africa, that erythroderma which means when the skin becomes totally red and chronically red, is and sometimes with signs of hyperthermia, dehydration, when the patient may be admitted to the hospital, is something which is maybe difficult to diagnose and to make as with a final diagnosis of atopic dermatitis resulting into erythroderma. So going back, so you need to take the history to see if there is flexural dermatitis and so on. This could be also a pitfall in diagnosis. Just minor forms like just perioral dermatitis could be like sometimes genital dermatitis, also purely atopic dermatitis. Also it's not so easy to diagnose. And again, you see this Denny Morgan sign. So the folds, which are 2 or 3 folds under the eyelid. So flares, of course, flares are something which brings the patient to you in your clinic. And so one of the problems when you see a flare is to know if it is only atopic dermatitis or if there is something else. And especially superinfection, we'll see with bacteria like staphylococci or streptococci, or some viruses, especially herpes viruses. So these are just flares, normal flares, I would say, just with mild superinfection, but they can be treated with topical steroids and even what we said, wet drops in another session. But sometimes it's true, impetigo, you may see some bullae or vesicles with pus, and this is generally a reason to go to a course of antibiotics which not clear the patient but improve greatly the situation. And more severe is herpes simplex superinfection and dissemination, because this is one of the parts of the skin barrier impairment in atopic dermatitis, is that the herpes virus group, or not only, because for example pox viruses or vaccines, so Coxsackie virus can spread on the skin much more than if there was not this atopic background. For barrier defects, probably immune defect, it is quite investigated in the field of dermatology. And this is a true emergency. This is a true emergency. You must have the reflex to know that this needs treatment with acyclovir, and this will solve the problem very rapidly. So this is probably something which is not so well diagnosed, I think, in Africa, because we read on PubMed before the meeting, and we were not able to find many reports on eczema herpeticum, so superinfection by herpes virus in sub-Saharan Africa, but we doubt that it does not exist. The other cases of eczema herpeticum, I would say that in the last 10-15 years we had also, I have no photographs here of eczema coxsackium with hand, foot and mouth disease, which is now also something to consider as a superinfection of atopic skin. But the punched out lesions like this, the parents say, it is different, doctor, it's not the same thing. you should believe the parents when they say it's not the same thing as the previous flare. Then I think among the pitfalls is something to understand. The more you treat, the more you get the risk of getting superimposed contact dermatitis. We had this problem with emollient, for example, in our department at the time of when the Pierre Fabre laboratory were putting oat in some of the Aven preparations. And we published a paper indicating where we find a lot of cases of patients having contact dermatitis to the emollient used in their families. So due to this paper, they stopped completely using the same oat. They just not they have just purified extract, but not the antigen which is responsible of contact dermatitis. But you see, for example, here the gel douche is also in this case you have to identify with patch testing the situation. And skin prick testing is useful sometimes, especially when you suspect food allergy, because food allergy can be not the cause of atopic dermatitis, but a trigger and a factor of exacerbation. And it is quite common. The more severe atopic dermatitis is, the more the risk of having additional food allergy because of the skin porosity which induces the entry of food allergen into the skin and not in the normal route of oral ingestion. And of course, you have also some occupational reasons in children, like PlayStation. So, the diagnosis of atopic dermatitis is based on this criteria, but it has been sometimes challenged, especially I remember in Middle East, in Asian countries, in African countries, because you don't have the same, all the same signs. But in general, this very simplified aspect, which has been summarized by the group of Hywer-Williams, is useful because still a majority of patients, they have this history of relapsing disease, of pruritus, and also the typical locations we have seen previously. So let's go to disorders which are not atopic dermatitis. So I already covered partially hand dermatitis. I will not return. But I think if you see babies, because atopic dermatitis is so frequent, you will see sometimes a patient coming with histiocytosis, Langerhans cell histiocytosis, and he may be sent because he has eczema. And so, because of the overdiagnosis of atopic dermatitis, you may be mistaken. So it's important to have a complete clinical examination to see if there is really pruritus, because pruritus is very moderate in true histiocytosis, to see if there are not lesions in the mouth, for example, some ulceration or something that can give you the idea to take a biopsy, because this is necessary in cases where it is not clear-cut diagnosis of atopic. You need to take a biopsy. And psoriasis is, I think, more difficult sometimes in childhood. And some patients have disease which maybe mix some features of atopic dermatitis and psoriasis. We'll see some examples. So just another point, which is probably easier in Europe than in this country or maybe in Africa, is to know if they have associated ichthyosis vulgaris, which means they have mutations in the gene of filaggrin, which is the precursor of the capacity of the outer layer of the skin, the stratum corneum, to keep water and to avoid dehydration. And if you see this kind of form, if you shake the hands, it's very different from normal skin. So you have this kind of rugosity of the skin, and this is an excellent sign of ichthyosis vulgaris associated to atopic dermatitis. So scabies, of course, is quite common, but especially when there are epidemics. I know that you have current epidemics in Madagascar. And what is a bit surprising for scabies is sometimes the patients are sent because of something which is not diagnosed and possibility of having atopic dermatitis. Is that, to the best of my experience, we see patients with treated scabies and some eczematiform reaction after treatment, but have not a clear experience of a patient having true atopic dermatitis and developing scabies. So I suspect there is something which may protect, but it's not so clear. And so the signs of when you see the palmar involvement, the axillary involvement, but you see in patients with true scabies, they may have this EADS, these eczema-like features. This is probably not due to scabies, but some eczematization of the patient. And these lesions are questionable. We don't know if it is truly the Sarcoptes scabi you will find here, but the patients, they have typical signs of scabies. Although you see palmoplantar lesions that's quite typical, especially in infants. You see, these are typical symptoms of this position is the position to make the diagnosis of scabies in infants. So infantile psoriasis, as I mentioned, frequently facial involvement. So this may be very misleading, but in general, you have the napkin involvement, which is rare in atopic dermatitis. The fact that you protect the skin in a napkin area is probably something which is dealing with also preserving the barrier function of the skin. So you have, in general, very few patients with atopic dermatitis and this type of psoriasis from dermatitis. So, but the combination is very suggestive of psoriasis. Since the other cases of psoriasis here, it could be very minimal involvement, but misleading because in the situation where you can see patients with atopic dermatitis. But also in general, pruritus is not as marked. Patients with pruritus may have pruritus, of course, especially during flares of psoriasis, but it is generally minimal. Again, other cases, this one is very typical, this you cannot say it is another thing than psoriasis, but looking at this flexural also, it could be more difficult. And also the gutata psoriasis could be also difficult. So contact dermatitis is not so common like this. And most of the patients that are seen in the hospital, they come because of suspicion of cellulitis. The first diagnosis when you see this generally is cellulitis, infectious with infection of the skin with streptococcus or staphylococci. But this one is a typical case of contact. There is no fever, there is no lymphadenopathy. I just want to finish with consideration on black skin, because of course we have difficulties on black skin, and we see patients even in Europe because we have a strong proportion of patients who is coming especially from sub-Saharan Africa, and we can see that it is difficult to assess severity in this patient because you may understand there is some erythema here, but it's not so obvious, this was, and you see this granular aspect of the skin, which is something you think it's quite disseminated. And you see also the flexural involvement, which is quite nicely shown, but it's moderate, but it is, and you don't see so well the erythema. It's more gray, we say, more dark than, and if you compare with a person of the same age, you see the difference. Immediately you see the lichenified and erythematous flexural involvement and the facial involvement. here is also another pitfall, more difficult, this one. This one is not a disorder maybe you may see commonly in your clinic, but you must have an idea of what it is, because I think also you need, of course, to have a confirmatory diagnostic test. And one is to take some hairs. Have you an idea of what it is? Netherton syndrome. And the patients, they have, of course, something that looks a bit like atopic dermatitis, but they have also this desquamation, sometimes with two lamella on the side of desquamation. So, and they have flares with desquamation. So these two, the sister and brother, they had proven genetically Netherton syndrome, and they were coming, I think, from Ivory Coast, which means that you may have also in Africa patients with Netherton syndrome, even if it's not something maybe you can easily access in terms of diagnostic tools. This is the same family, you see, and you may see also that it is also heavy lichenified here. It's already looking like atopic dermatitis. What is your diagnosis here? Is it numeral atopic dermatitis? No, it is another disorder which is probably more common on black skin than on white skin. It is lichen planus. And lichen planus, you have the true lichen here. You have the thickening of the skin with this very nice traits on top of the skin. So one of the difficulties I mentioned, is it pyoderma or pyoderma on atopic dermatitis? I think this is sometimes difficult to say, but this is, I think, typical pyoderma, and the patient has no flexural dermatitis. Just to show you also this question of papular atopic dermatitis, because this was discussed, I think, after the first presentation of Professor Raplanoro. So is this papular pattern common also in Madagascar? So it's quite common when we see also patients with black skin in Europe. So you see this fine papular involvement, and also you see some flexural involvement here. See the same patient, we see the papular. So my colleague from South Africa yesterday said it is follicular. I'm not sure it is follicular. In my opinion, it's not follicular. It could be sometimes on the follicle, but most of the time it's not follicular atopic dermatitis. You see, this is another case. You see some of the micropapules like this. Here again, but when you see this, maybe you can consider scabies, of course. And you have to be very prudent. So is it scabies or atopic dermatitis? It is scabies. But in some other cases, so sometimes it's difficult because the itchy part is not so obvious in some patients, and it could be another disorder. And this disorder is lichen nitidus. It's difficult to make the diagnosis without a biopsy. But the patient in general, they have not pruritus or very mild pruritus. But it is not uncommon, especially on black skin. The other cases of lichen nitidus. And the last one I want to emphasize is the change in pigmentation, I think. This could be also quite misleading, because when you see this kind of patient, even in young children, you may consider also other disorders. Of course, when it is really white, you think vitiligo situation. In some countries where they have high cases of T-cell lymphoma, you may also consider T-cell lymphoma. So in some cases, you may go up to a biopsy. But in general, it's just papular and hypochromic atopic dermatitis. This one is very marked on the forehead. Scoring, of course, the patient is very difficult. So this is the work done by the group of Professor Faye from Mali. So they validated this new version with photographs with patients originating from Africa, and I think it's quite useful when you want to score the patients rather than having the conventional one. Use the app which shows the photos on black skin, and just to show that there is a good correlation with the patient assessment, which is named patient-oriented scoring and scoring. So in summary, and we'll conclude that it's a very common inflammatory skin disease, especially in children, but not only in children. It's highly pruritic, so this is something to remember, that because it's important in the differential. It could be misdiagnosed because of overdiagnosis, and of course you may in some cases perform a skin biopsy when you are not sure of the diagnosis. And just to finish with what I showed, it's atopic dermatitis on black skin is difficult because assessment is not so easy, and assessment of treatment could be more tricky. Thank you very much. Just to mention, those of you who are interested by atopic dermatitis, our next Congress is in Canada. It will be in October, from 17th to 19th of October in Montreal.
Thank you, Alain. That was a very comprehensive overview, seeing the pitfalls and the difficulties on white and colored skin. One or two short questions for the sake of time.
So I have any question. I have just a comment. I would like to thank Monsieur Salem Tayeb for sending me back. 20 years later when I was in Bordeaux. So it was very interesting. So I just, maybe there are many cases of lymphoma missing because in hypochromic patches, because it's very common most of the time. We have a genesis of Peter's album, something like that. But I think when we explore in some patients, we could find some cases of mycosis from it. Also, thank you so much.
Mm-hmm. There's I go over there.
My name is Brunel. I am a third-year medical student in the University of Tananarive, and I have one question. Why is quick testing used in the diagnosis of in the case of food allergy? Since if a patient has a food allergy, wouldn't the patient conduct the circulatory system of the patient conduct directly the allergen in the cells of the skin? But if we use the prick testing, the allergen stays just on the skin, so
prick testing means that you put a drop of the allergen and then you prick through the skin, so it goes into the dermis, and the action is to liberate histamines from mast cells in the dermis. So it's not epicutaneous. Epicutaneous testing is a contact dermatitis test, and you have late readings at 2 or 3 days after you leave the product in contact to the skin for generally 48 hours. you remove and you read the day after. The best way to read the contact test. But I think that probably in your clinic you have maybe limited access to allergy testing. I don't know how it is in Madagascar, because in many places, even in Europe, it's difficult to find the qualified personnel for contact testing. Generally, they do prick testing, of course. It's easier with the person specialized in allergy, but they don't perform so much patch testing, which is, in our opinion, more valuable in terms of finding some relevant triggers, even in atopic dermatitis.
So it's my pleasure.
So just to introduce, Peter Schmidt Gandelmeier is working in Zurich, Switzerland. Is highly specialized in this aspect of atopic dermatitis allergy testing and research. And I'm very pleased to introduce this talk on this management on the allergy side of atopic dermatitis.
Mm-hmm. Thank you for the introduction. What I want to try is to give you a little bit overview what can be compared between African and European thing. You know, it's a spider web where we're in genetic factors, immune system that is reacting more, environment where we have allergens, skin structure, and which is different, so it's not as efficient the skin as in others, and the nervous system, which is things. And we have already heard that it changes from ages. And we know much more about immunology. So all what is going on here has been discovered much more in the last years. It's puzzling, I know, but some of these substances like IL-4 or IL-13 are now addressed by treatment. We will hear more by Professor Wollenberg of it. So to my students I explain these substances are the SMS between the cells. One cell tells the other to do something, and then it enhances the inflammation or it reduces it. We also know much more about the microbiome. So this is the totality of bacteria which is on the skin or in the gut. It's not anymore just one. And the microbiome, which is the fungal aspect. And there's very many risk factors which are discussed. This is hypophysis. So for example, if you have a too clean environment, you are a higher risk to develop, for example, respiratory allergies. If there's allergens around, it can enhance allergies, but if you avoid too many, it's also not good. And vitamin D and other factors play a role. One could speak a long time about this. It's not fully clear yet. And the barrier is reduced. This is a very nice paper, but very complicated, that the skin facilitates entrance of germs and others. And what I want to do now is a little bit to see these factors between skin as we see it in Zurich, in Switzerland, and I've worked quite a while, and I'm still co-working with colleagues in Moshi in Tanzania. So to see what is happening there, and it's all based on this meeting also we had a few years ago with Professor Raplanaro from Madagascar also, and there are studies from the United States which tell, sorry, that was the wrong one, that there's a difference also in the immunological signature. So nowadays we have data mostly from Americans or Europeans, from Asians, and we have it a little bit from small children, but there's very little about African immunology background. So we decided to do cooperation between Emma Gutmann, she's one of the leading researchers on this, and we sent one postdoc there, Claudia Lang, and in our lab, and of course the colleagues in Moshi, where we compared the patients. So we start with 10 patients with atopic dermatitis from Tanzania, and 10 with atopic dermatitis from Switzerland, and 10 healthy controls in both countries. And then you can see, we just saw some differences. I will not enter into all this immunological difference, but we saw that there's striking difference between the immunology in these 10 adult AD patients from Tanzania. And if there's already a difference in 10 patients, we extrapolate that there will be more difference in more patients. So actually, these cytokines, they are a little bit more related to the Asian type of atopic dermatitis, or even a little bit to psoriasis. And when you were mentioning we have more the extension site involved in colored skin or in African patients, it might have to do with these immunological differences. And there's now more and more studies ongoing which show that there are differences. For time reasons, I will not go into detail, but it's just showing that some patterns are much more pronounced in European or American patients than in Afro-Americans. They are more investigated than African patients, and that would mean that some of the treatments that are focusing on these cytokines might work less or might work better in African patients, or could have more side effects. There's more studies now also investigating, comparing whether it makes a difference whether you live in a village or in a rural area. And there seems to be some difference, and we also know that urbanization is one reason where you find atopic dermatitis more commonly than in rural areas. This is a quite confusing paper. There's many cytokines which have changed, some have not changed, but it's a start to look at all of this. Something which might be more concrete. A few years ago, we did a study in children in atopic dermatitis in South Africa, and what was a striking finding that sensitization against mouse is much more common in AD patients. This is not so surprising, but we could really correlate it with the socioeconomic level. The poorer someone is, the more he's sensitized against mouse. Maybe this has to do with the hygienic condition. If you live in a, let's say in a very poor condition, in a hut or something, of course, there are more, the probability to have mice in the household is much higher than if you have a big villa with maybe 2 cats and a dog inside. So this might influence. The similar finding has been found in the United States for asthmatic patients. Also, the lower their income is, the more they are sensitized towards mouse. It's a little provocative, as I say, sensitization against mouse is a sign of poverty, but it goes into that direction. There's more and more studies showing that sensitization, and you were mentioning prick test, this is IG, which we measure, as Professor Taye explained. We have histamine release. You can do this for inhalant allergens, for here you see house dust mite, dog, cat, horse, mouse, or for food allergens, egg, peanut, soya bean, or cow's milk. And you see always that sensitization are also higher in urban patients with atopic dermatitis, so they have a higher risk to develop sensitization. Sensitization means that you can detect IG either by skin test or in the blood, but it does not mean really that you have symptoms. When we speak of symptoms, then it comes to the word allergy, which is different. So this is sensitization. And we know atopic dermatitis is just the tip of the iceberg. There's many more associated diseases like infections, which can cause severe problem. It's staphylococci, of course, that can make septicemia and others. But nowadays we speak more about a microbial disbalance. There's an increase of staphylococci, a decrease of other bacteria, and if this balance is disturbed, it enhances the disease. So we are at the beginning to understand this, and there's also treatment to enhance maybe beneficial bacteria. We call this probiotics. There's studies ongoing to give it as a food intake or to apply it on the skin, and with this we can maybe also influence that aspect. Osteomyelitis is one of the complications. Now I come to the allergy itself, so external things that may enhance the disease, and for sure, especially in adults, respiratory allergies like asthma, rhinitis are more common in patients with AD, while food allergy is more common in children. However, if you have a positive allergy test, it's not the proof that atopic dermatitis is caused by that. Very often parents then think, if I avoid milk or whatever, soy or egg, the atopic dermatitis will disappear. It's a trigger, as we heard. It's not the real cause. So here you see some trigger factors. Food hypersensitivity is more common in infancy and is decreasing. In adults, it's rarely a real important cause. In adults, it's more bacterial infections, viral infections, and inhalant allergy, so allergy against house dust mite and others. Now, we did recently a questionnaire where we asked doctors how often you see asthma, how often you see atopic dermatitis. Both is quite common in sub-Saharan Africa. And there's the study from your department, Benja, which also showed actually quite commonly food allergy, 16%, allergic rhinitis, asthma is lower, this is the same thing, and conjunctivitis. So what I want to show with this, please ask your patients if they have a skin problem, whether they have something like that, food allergy, or also running nose, itchy eyes, problems to breathe. Also here in sub-Saharan Africa, this plays a role. So what we were looking at, our small study group, whether they were sensitized to food, to plants, So to food, to plants, and now we are also looking on bacterial and pets. Usually they don't keep pets in their house, but dogs are strolling around. And we were first measuring total IgE, and this is something easy to measure, and it's usually elevated in patients with atopic dermatitis, and this we saw in the Swiss and in the Tanzanian patients, but not in healthy controls. Of course, we were also looking for parasites, because parasite can also make an elevated IgE, and it's common. Here we didn't find a difference between the two populations, which means that at least in these populations, helminths were not very common. We used a very sophisticated assay where we can measure 230 different allergens from 30 microliter of blood. So we got some interesting results which we wouldn't have seen otherwise. So it covered plants, it covered diverse microbes, dander, and a different variety of food. And we were looking, for example, sensitization to malassezia. I go to the next one. You all know this colonization by this fungal disease, which can penetrate in atopic dermatitis because the skin barrier is looser and we have an immune system that reacts easier to it. So we find IgE against malassezia. This is very typical for atopic dermatitis. And we were really surprised to see IG against malassezia only in the Swiss patients, not in the Tanzanian patients. That was, and it was striking, even not in very severe AD. Of course, it's a small study group, 10 patients, but still it was, we measured also against, this is the molecular patterns, but we measured also the whole fungal IG. We cannot explain, but there are signs that IL-17 is important for the defense against fungal colonization. And if it fits together that patients with from sub-Saharan Africa have a more IL-17 pronounced pattern immunologically, that might be one of the explanations why there's less sensitization. This is data from a mouse model. It's still a hypothesis, but it's an observation that we for sure want to follow up. And you know, patients with malassezia, very often they have this head-neck type. I wonder, maybe we can discuss whether you see it often in your patients or rarely. Then the house dust mite, we found it more commonly in Swiss patients, but it was also there in the patients from Tanzania, although that's not a typical climate for house dust mites. While cockroach sensitization was much more pronounced in the Tanzanian cohort, and I guess you know that cockroaches are really more common in some households in African settings than in Swiss households. There's other studies from South Africa where they also compared Xhosa children. This is a very native tribe, if you want. They still have a click vending, and they looked at children at different ages, and they, for example, found for food allergy that peanut allergy is very common, but in patients with colored black skin, it's much rarer than in the mixed race skin, that means in other ethnic background, and especially this RRH2 is usually a sign for a very dangerous peanut allergy. So, and this was almost not found in the black community. So they are much better protected against peanut. Even if you find IgE, even if you have positive skin prick test, they will not make severe allergic reactions like anaphylactic shocks to it. So whether it's genetic, it's other nutritional aspects, it's not clear. And it's just that if we say allergies is not common in this setting, this data from South Africa says also it's common, and there's also an urban-rural difference. So we were looking also for food, of course, and what we found is a lot of sensitization against seafood, and especially this protein, tropomyosin, which is in seafood. And it was much more common in the Tanzanian group, only in the patients. So this is seafood. And seafood, we know, contains tropomyosin. It's cross-reacting with house dust mites, with cockroaches, and of course seafood. It all links. However, if you think about seafood, as an allergist, you also have to think about house dust mite and cockroach, so because it's cross-reacting. So if you have someone with seafood allergy, has also mite allergy. However, in Tanzania, in the Kilimanjaro region, oh, that was the wrong one, no one eats seafood. It's far too far away. So what is this sensitization to? Is this purely cross-reactivity or not? We were really wondering. And then we went on the market and saw this is what they feed to the chicken. This is the protein source number one for low-income people. And with very sophisticated methods, we could detect seafood protein in this chicken meat. So as they grow up the chicken with this seafood, most probably there's still enough seafood protein in the chicken to cause at least sensitization, and we have 1 or 2 patients who reacts to chicken who is seafood allergic. We are beginning to develop that, but that's an interesting observation, and now we've started to do the same thing in Switzerland. because our chicken are fed with soy, and we have really detected soy in some chicken, which might cause a problem to a highly soy allergic person. This is just, we had a visit once in Uganda. There's a strong cooperation for infectious disease. They also have a lot of skin problems. STI, eczema is also leading, albinism, and cutaneous drug reaction is a really severe problem. Why I'm going to Uganda? That's the reason. For them, grasshoppers is a delicacy. It's really very common to eat it, and I got this meal offered, and of course for hospitality you eat it. It's a little bit like chicken, but it's not only in Uganda. In Switzerland we have switched, and since 5 years these 3 insects, so mealworm, grasshopper, and migratory locust, are also allowed as food. We don't eat them like that, but we get insect burgers. And of course, insect is a very good source, actually, economically, but it causes allergies. And if you think you never eat insect, it's in the waxing of fruits, it was in Campari, it's in many power drinks. So you can calculate, we eat about 1.5 kilo insects per year, whether we want or not. So enjoy your next drink with insect. This is just a summary. I've read it for the sake of time. I don't go into details. We plan next steps. We had a very small group. Now we are already working on 60 and 60 patients, more healthy controls. We also do more microbiomes and other blood cells. We measure the skin barrier. We had to be sure it works, also with sample storage, with measuring on site, and we will be very excited what comes out, also looking at cytokines on the skin level. One thing we will also do, we will analyze the sewage, because with this you have a lot of information, and there are very sophisticated methods to measure antibiotics, drugs, proteins in the sewage, and you can discriminate very well if someone lives in a rural area from the sewage or in an urban area. So to summarize, just to tell you, there's really, of course there are similarities, but there are a strong difference immunologically, and we are just at the beginning, and I can only encourage all of you to join in such research. I know it's costly, but together we can find grants to understand better the disease, also to understand maybe better what we will hear now, more tailored drugs, if we address some cytokines, maybe they are not so important or they're even more important in this population, and these are very efficient but also very costly drugs. And of course, allergy, we have different patterns, of course we have a different environment. We have maybe better protections, but others might be more dangerous. And of course, how you cultivate or how you breed your food sources is important, and there's much less control in rural settings, for example, in remote Africa. So with this, I would like to thank to my team, and best regards from Switzerland. Thanks for your attention.
Thank you very much, Peter. So you said that the chicken are eating shrimps or what?
Yeah, they are, to chicken, if you want them as a food, you grow them 6 to 8 weeks, and they need a protein source, and they give them this seafood. In Switzerland, they would also like, because it's very powerful, but it's not allowed. So it's cheap on the market, it's dried seafood, and it's the staple food for this young chicken. It took us a while to find this out.
Are there questions to Professor Schmidt, Gantelbeyer? There's no question from Mali or Mauritania?
Yes, thank you for this nice presentation. You talk about this difference between black and Switzerland people and white people. If we do the same study, do you think is it useful to do the same study considering different phenotypes?
I'm sure it makes sense, because it's of course not only the colored skin, it's also the environment, the habits. It might be different in Madagascar, in Mali, in other places. And there's doing studies in Afro-Americans which live in the United States. They have the colored skin, but complete different conditions. And some of these patterns are different. Some are typically, let's say, same ones from the Tanzanian, like the colored Americans. So something is genetic, some is environment. So therefore, it absolutely makes sense. Also in South Africa, the Xhosa and others, rural, urban, we are just at the beginning. And it's really largely unexplored still, this area, in this continent.
No further question?
Yeah.
No.
It's okay.
Thank you.
It's okay.
Thank you very much.
Thank you.
So the next speaker is Professor Andreas Wollenberg. Andreas has been pursuing studies on atopic dermatitis for many years, and is currently also in the executive group of the International Society of Atopic Dermatitis as our Secretary General. And he is also he's a major investigator in the field of new drugs, including biologics. And he has also the experience of children, so he has all the qualities to speak about new developments in atopic dermatitis.
Dear Alain, thank you for the introduction, and Benja, thank you for the invitation. Well, here we are. There is no time for question. It's 5 minutes past 5. So I'll try to still deliver some aspects of the new treatment developments in atopic dermatitis. I will start with a short introduction and then go along those things that are currently either hot topics in my home country or that may easily be transferable to Madagascar. So, when we have atopic dermatitis, we have a defective barrier. That is known. But it is actually two barriers. It is the stratum-corneum barrier, we readily influence with emollients, and it's the tight junction barrier that is more relevant for the water loss that we have. The epidermis of atopic dermatitis is much thicker, but is dysfunctional. You see the spongiosis. Here is much more water loss, and even if it is thicker, it does not work that well. When we look at the quality of the tight junction, that is excellent here. You can do immunofluorescence studies, but it is not good in the AD lesions. If you measure, here is something where you can easily see the differences to atopic dermatitis, and this is what gives the basis for the high water loss in our patients. We want to influence this, and this is a direct consequence of the ongoing inflammation underneath the skin. If we have mice that are completely missing the tight junction proteins, these mice die from dehydration within 1 day. So you cannot survive without the clotting. When we are looking what is happening in non-lesional atopic dermatitis skin, we see that the transepidermal water loss is higher than in normal human skin, but lower than in atopic dermatitis lesion. And the same thing, the hydration, highest in normal human skin, lowest in atopic dermatitis lesions, and somewhere in between in the non-lesional skin. The IgE receptors on the dendritic cells are highly upregulated. Data that I would have prepared myself on the flow cytometer years ago. So we have not a normal skin in the seemingly normal skin of atopic dermatitis, but there is minimal inflammation. And this inflammation is a target that you can use if you treat it with a minimal anti-inflammatory agent. If we look at what is happening underneath this barrier dysfunction, we have a mixed cell infiltrate where the Th2 cells are the backbone. This is why the monoclonal antibodies like tralokinumab are functioning in almost any patient. And they improve the disease quite well. We have nerve sprouting of the sensory neurons, and we have a second type of dendritic cell moving in named the inflammatory dendritic epidermal cell. So here is vicious circles running for IgE-mediated antigen presentation, and there is super antigens coming from the staphylococci from the microbiome. So this would also be a possible target. When we look at the composition of the epidermal dendritic cells in the skin, we have the normal human skin with only Langerhans cells. This is what you learn at medical school. In atopic dermatitis, you have a strong population of inflammatory dendritic epidermal cell. They are together with the lymphocytes, the backbone of the inflammation in AD. Whereas in lupus, you have plasmacytoid dendritic cells in high levels. And these produce type 1 interference. So it is like a yin and yang phenomenon of the skin. Psoriasis and contact dermatitis are in between, but atopic dermatitis and lupus are the extremes. Because we need this part of the immune system to protect against herpes virus. We have, because they are missing in atopic dermatitis, a susceptibility for herpes virus. And if I ask you as dermatologists, have you ever seen lupus herpeticatus? It does not happen. The immune response that is needed against viruses is fully active. People would like to define endotypes of atopic dermatitis, so to make a clear-cut subdivision of the immune system and of the genes that are active in atopic dermatitis to treat specifically these endotypes. But we are not there yet. Precision medicine is still something for the future for atopic dermatitis. It works maybe with melanoma at present, but not with atopic dermatitis yet. It will come. From the European Task Force on Atopic Dermatitis, an illustrious group of 30 to 35 dermatologists working throughout Europe, which has been led by Alain Tailleb for 10 years, and also by myself for 10 years. That group has made kind of a therapeutic step-up, step-down approach, where we would give therapeutic suggestions for every type of severity. And when we look at what we have, everybody should get a good emollient therapy. The mild patients are usually well off with a reactive therapy, which means treating only eczema when you see it. Here we have other means and the art of dermatology, and here is the systemic treatment. I will give you some examples what you could improve here, and I give you some examples for this type of treatment. Emollient treatment of atopic dermatitis is as old as atopic dermatitis. The first patient whom we knew with atopic dermatitis was the emperor, the Roman emperor Augustus. We read in the old books that he would actually be anointed on a regular basis and that he was scratching himself a lot with a scratching iron. So he, together with the people from his family who were also atopics, would be the first users of emollients. We need a humectant, which is something that increases the water binding capacity of the skin. That may be urea or glycerol. Urea is the only substance listed by the WHO as an essential medication for atopic dermatitis currently. So we need to change something here. We have something that is sealing the humidity in the skin, which is usually petrolatum. And we have now the new group of emollients plus. This is drugs that have additional active substances here in their emollients, but these do not carry a drug status. There is some efficacy, but the substance itself is not considered a drug. So you can still sell as an emollient, and this is one of the new developments that we have. There is different types that we have plant extracts, like the extracts from small oat plantlets that Professor Peter Schmidt-Grendelmeyer was mentioning. They are devoid of the protein, but only have the active ingredients, the riboflavins or the saponins. And we have bacterial lysates, that is another hot topic. You take bacteria that are apathogenic, you lyse them, and they activate the immune system. Don't forget, 1/3 of all atopic dermatitis patients has contact allergy to the ingredients of their topical drugs. So you better use hypoallergenic drugs. This emollients plus is a concept that was first coined in the European guideline of the year 2018, and the list that had been relatively short in the beginning is now getting longer and longer because more companies are bringing products to the market that fulfill the definition. So, to summarize this part, if we want to improve the epidermal barrier, we should reduce the degradation of the stratum corneum by pulling the pH in an acidic pH region. We should hydrate the stratum corneum with glycerol or urea. We should supplement things for the lipid lamella, and we could do some kind of physical measurements to reduce the staphylococci. This is a good way to act. The patients think that atopic dermatitis would run in flares, and they are afraid of the flares, and they are not predictable to them. If we look more carefully, I showed you the laboratory, then we see that underneath our visibility threshold, there is also disease activity. We just cannot see it. The reactive therapy is that we start with just treating when we see the eczema. This is how I learned from my teacher, Otto Braun-Falco. With proactive therapy, we do a long-term, low-dose anti-inflammatory treatment of those areas where eczema tends to come back. It is an easy concept, and it is a concept you can do without any problem here in Madagascar. About half of the patients will stay flare-free for a full year if you do. Of course, when you see a lesion, you must add an intensive treatment on a daily basis, whereas this low-dose treatment usually is given twice per week only, on Monday and Thursday, or Monday and Friday. So the reactive treatment, following what you see, is the old thing, and it is good if you have mild eczema. The proactive treatment, after the flare, you continue with low-dose anti-inflammatory treatment where the eczema tends to come back. This is the new thing. We coined the term in the year 2007 for the first time. Long-term, low-dose, intermittent application of anti-inflammatory therapy. It is used from Helsinki to Cape Town and from Osaka up to Vancouver, all around the globe now. We could show that this really works in papers with topical calcineurin inhibitors for the first time. So this is something that really gives good evidence for the concept. And we see the difference between those two Kaplan-Meier diagrams. They work like Kaplan-Meier for melanoma, just that our patients don't die, they get a flare. If you look at the curve of the placebo, you will see that half of the patients get a flare after about 2 weeks. And this flare-free time is prolonged about tenfold, and 1 year long, about half of them will not get a single flare. So this is very good data showing the efficacy. You do not need topical calcineurin inhibitors. It also works with moderate topical steroids. So if you have something like class 2 for topical steroids, it is cheaper to use and maybe more appropriate for Madagascar. It works. You can use. Now, we have different severity, mild, moderate, and severe. And at present, we define this with the SCORAT. The European Task Force on Atopic Dermatitis made that score, and below 25 is mild, above 50 is severe. But there is now also a functional definition, which is intermittent topical therapy is enough, disease is mild. Continuous therapy or proactive therapy is needed, it's moderate. Systemic treatment is needed, it's severe. This is the functional definition. People are now softening the definition of what is mild, moderate, and severe. They change and give new definitions. If we have different questions to ask those patients who are difficult to treat, there is a number of things we could do. You learned this from Professor Taillet. Think about the differential diagnosis. You learned from Professor Schmidt-Grendelmeyer. Think about hidden allergies that may trigger the disease. But if everything is still refractory, then it is time to think about systemic therapy. My good friends Christian Westergaard and Mehdi de Leran would make this mind map of atopic dermatitis. It gives areas where you should talk to your patient if you want to find the ideal treatment. The ideal treatment you cannot follow with a logical Boolean tree. You have to talk to the patient and ask and find out what do they like. We published this in a paper in 2018, but the original artwork comes from Denmark. I give credit to them. The treatment landscape for atopic dermatitis in my home country is based on emollients, topical corticosteroids and calcineurin inhibitors, UV treatment, and proactive therapy. We have some traditional systemic treatment, but this is more and more abandoned now in my country. We still use cyclosporin for the acute intervention. It works in any of these subtypes. And we have methotrexate. And methotrexate, as you will know, it is stable in the heat, it is cheap, and the people who come along with it on the short term usually also tolerate it well on the long term. This is why my friends in India have as standard treatment the methotrexate and nothing else. We now have 5 new systemic drugs, and I want to give you some details on these, how they work, and how it's running. I will start with the biologics. There is two cytokines, IL-13 and IL-4, who are binding to the same alpha chain of the receptor. And you could block the binding of both cytokines to that alpha chain, and then there is no signaling for IL-4 and for IL-13 by this receptor. This is dupilumab. You could capture the cytokine IL-13. There is about 1,000-fold more IL-13 in the atopic dermatitis lesion than IL-4. So, just blocking IL-4 is not useful in AD. But just blocking IL-13, this gives you a drug that you can use. Unluckily, it is quite expensive, like the dupilumab. All these biologics are relatively expensive drugs. The third one, the lebrikizumab, is studied. Now the phase 3 study is finished and it is submitted to journals, and we will see if it will come through on the easy way or not. So these two ones are relatively similar but not completely, because they have differences in the way how they work. But all three of them go for the type 2 response, the Th2 response. I give you only one of these charts. If a company-sponsored presentation comes, you have 40 or 50 of these, and you are getting mad. I give you one of them to show it works fast for the signs and for the symptoms. This is already adolescent data, because dupilumab is on the market since a number of years. So we have adult data, adolescent data, children data, and there is now even studies being done from 6 months and above. It works in all age groups. It's fantastic. The laboratory safety of dupilumab is excellent. You do not need to make a single laboratory test before you start dupilumab. No check of liver, no check of kidney, nothing. We showed this in a number of trials, and this is true for adults and for children. The key problem with dupilumab is conjunctivitis. The majority does not get it, but a significant number of patients, depending on the trial, will have it. Red eyes, it's always both eyes. And the risk factors are severe AD or a pre-existing conjunctivitis that you should have to know. We only see it in atopic dermatitis, but we do not see it in asthma or polyposis nasal trials. This is how it looks. The conjunctiva is red, there is some tearing in the eye, and you have accentuation of the limbus area. And what do you do if you see it? You treat topically. You can use topical cortisone eye drops. This is the preferred substance because there is also better and less good topical steroids with ophthalmologists. This drug penetrates only a little in the anterior eye chamber, so it's safer. It's available all around the globe, and it is not that expensive. So it is something that we recommend and like to use. You could also use tacrolimus ointment on the eyelid rim. This is readily available. You need only minimal amount, and a little of the tacrolimus comes from the lid rim to the tear fluid and does the work. Very easy. Cyclosporine eye drops you need to prepare. They are much more difficult to make. So here for Madagascar, probably this is the easiest thing, or this. You could use both if there is a patient who has the problem. Some patients develop a new psoriasis because if you take out the Th2 backbone of the inflammation, what sometimes stays over is an additional reaction that is usually covered underneath the atopic dermatitis, and if you trigger it with stopping the oral corticosteroid that should never have been given, a psoriasis comes out. So the patient switches to another skin disease. one of the patients whom we published from our department where a very strong reaction comes out. Histology, full-blown psoriasis. It happens. In those cases, you have to broaden the approach of treatment. So probably cyclosporin is the easiest thing to use. Tralokinumab, I told you, works well. This is one of those waterfall plots to show how it's looking at week 16. But if you continue treating a little longer, you see that more and more patients are reaching the target of EASI-75. So tralokinumab is not the fastest drug available, but it is extremely safe, like all Th2 blockers, and makes less conjunctivitis as far as we know even than the dupilumab. The flare prevention that I showed you with topical drugs also works with Th2 blocking agents. So we can reduce the risk for a flare about 4-fold if we use systemic treatment like the dupilumab. If we compare the Kaplan-Meier, you see that this is the control, which has a topical corticosteroid, and this is the topical corticosteroid plus the dupilumab. So you see there is significant difference, but most of the patients you see do not flare on the long term if they would have a well-conducted topical therapy. Let's finish with the JAK inhibitors. These are molecules that interfere with cytokines binding to receptors because there is cross-phosphorylation with Janus kinases. And this then leads to phosphorylation of the STAT factors. And the phosphorylated STAT factors, they are going to the nucleus, and then we have a reading of the genes that are specific down there. So this way down here has the need of 2 Janus kinases. They always work in pairs. And there is only 4 of them. So if you have 4 of these kinases and they work in pairs, it is an easy calculation that there is 10 different ways how these could be combined. So it has a better specificity than using broadly acting drugs like cyclosporin or methotrexate, but it is not as specific as a biologic. Think of a boat that has 2 outboard motors. You have many different boats, but only 4 different types of engines. And if you take one of them out, you have a relatively more specific inhibition of the signals. A lot of biological signals are needed that also use the JAK-STAT pathway for hematopoiesis, for antiviral responses, and others. And most of the drugs that we have to treat atopic dermatitis inhibit this Janus kinase 1 in the strongest way, and the other ones much less. So all these mechanisms that you read here are somehow dependent. We do not want to block it completely. We just want to lower the efficacy of Janus kinase signaling. What happens if you have a Janus kinase 1 knockout mouse? The mouse dies. It is not able to survive. So let's have a look at the most important cytokines in AD. Here, everywhere, Janus kinase 1 is involved. We have 3 different systemic drugs licensed in my home country to treat atopic dermatitis, and there is a number of Janus kinase inhibitors that are used topically. These substances are very small, 250 Dalton. They can penetrate the epidermal barrier very good. They are smaller than cortisone molecules, than glucocorticosteroids, so you can use topically. They work faster. If you compare, the green one is the dupilumab, it's now the benchmark. The JAK inhibitors work much faster and are also a little more effective. But the Th2 blockers on the long term, after some months, they catch up in efficacy. So clearly, Janus kinase inhibitors are fast drugs, especially the effect on itch comes within days. 1 or 2 days, and the atopic dermatitis patient says, I don't itch anymore. It's just great. But the FDA that is watching over drugs in America, they would do a black box warning. The origin of concern was that a broadly acting substance given in combination with methotrexate to patients on average 20 years older than atopic dermatitis patients with lots of more comorbidity would have a slightly higher risk for severe reactions like thromboembolism, phlebiothrombosis, and others. But then they extended the concern. They said if it's TOFA, it could be all other JAK inhibitors as well. If it's systemic use where it's shown, it might also come from topical use. And if it's from rheumatoid arthritis patients, it might be any other type of disease as well. So in the end, we have for all drugs, for all indications, for all preparations, no this concern. But we must critically decide for ourselves what does it mean for atopic dermatitis. Here is where we have those drugs that now have a black box warning. We do baseline screening before we initiate JAKs, and we recommend the same baseline screening for all Janus kinase inhibitors. Full blood count, renal count, liver values, lipid profile, muscle enzymes. There is a few patients who have elevation of CK. It's not the old patients. Most of the problem comes with old patients. The CK is the young bodybuilders. They want to look good, they go to the gym, they get it more. Of course, we screen HIV, hepatitis, tuberculosis. And if we have women who might give birth, check for all pregnancy-related issues. It's a good idea to do vaccination for chickenpox in my home country, varicella vaccination. There is a number of patients where it is better to not use the oral Janus kinase inhibitors. So, as a general rule, the older the patients are, the better it is an idea to maybe go to other type of drug. And elderly patients should use a lower dose. All of these drugs come in 2 different doses. A higher dose, usually double as high as the other one. So you would start in the younger patients with a higher dose, but then go back after some time. There is this basis for the black box warning, but the increased risk is probably very little increased only. The good thing is, if you need to do something like vaccinate for yellow fever, you just stop Janus kinase inhibitor and it's out of the system within a few days. It is a drug that acts fast, but it goes away fast as well. So let's have an outlook with a few philosophical aspects. If we have something that works very well, it may also have more side effects. So usually there is a good relation between the wanted and the unwanted effects in any drug. If something has too many side effects, but has no increased value in efficacy, we stop using it. Like the traditional immunosuppressants. They are now like azathioprine. They are now getting out of use more and more. But if something comes that is as effective and even safer, like the biologics, this will now become a new standard. We are in a moment where this changes. We heard today the presentation about adherence in Madagascar. This is our overview of the factors influencing adherence. We looked at anything in chronic skin disease, and we cannot change our patients' factors. By the way, if you review, this was the question that Peter Schmidt-Grendelmeyer had, the married patients usually have a better adherence if you look at the trials. Disease, we can't change the disease that the patients have, but we can select the treatment, and it's our decision how we talk to our patients, how we interact. The best adherence is with intravenous or subcutaneous injection, and the lowest one is with topicals. We have to keep that in mind. Topicals have the lowest adherence. This is the new stepped care approach of the European guideline. It has been accepted a few days ago, and you are the first to now see it, because I'm now allowed to show it, because it is now in press in the GADV. All the new systemic treatments have the same strong recommendation. We have the methotrexate still with it, and the cyclosporin has even a stronger recommendation than the methotrexate. Most of the other things have stayed, but emollients are still the basis for anything that we would use. For the children, there is less substances licensed, but the basic principle is the same. So it will come out in the next weeks, and it will, once it is published, be available to download for free from the GADV homepage. So you can just log in and download. I want to finish with a view of the Oktoberfest in Munich. It was not taking place for 2 years, but now we have it. We liked very much the good beer at Madagascar. We had a Munich Doppel, and we had a Gold, and we had 3 horses, and however they may be named. And I must say that all of us, we liked to try it, and we can invite you to come to Munich to enjoy the Oktoberfest this year. So maybe you meet some dermatologists whom you know, because we go to the Oktoberfest also once a year. By the way, one of these tents houses about 6,000 people. So if everything is full. Clearly that we did not want to do it during Corona. So thank you.
Are there some questions or comments? Professor Barr?
Yes, thank you for this very nice presentation. Three points. First, while talking about Munich, you did not say something about the football, huh? Bayern de Munich. Yeah, that's one.
The football in Munich.
Yes. Second, this presentation is very nice, and it shows there's a necessity for the young dermatologist to try to be more and more conversant with biological aspects. Dermatology is moving like all sciences. Before, we all our clinicians now, and more, we look at biological aspect. We may not have a laboratory like Professor Alan Tayeb, but we have to be more and more familiar with all these aspects if you want to practice dermatology. Third point, I want you please to elaborate more about methotrexate. Are the conditions, the biological exam to prescribe methotrexate are the same? What should we do if you want to prescribe methotrexate? What should we do if you want to follow a patient using methotrexate? And what are the conditions for people, for young women and young men to use methotrexate? Thank you.
Let me start with the last question. Methotrexate is a teratogenic drug. So women of childbearing potential must not get pregnant. So before we start, beside doing a pregnancy test, we prescribe some kind of oral contraceptive. This is standard in my country. And the way how you ensure that the women will not get pregnant is something that is usually regulated on a country basis. So we have to ask Benja how it is running here at Madagascar. But they should never get pregnant. It has a highly increased risk of teratogenicity. Second, we check for liver enzymes, we check for kidney, we check for HIV, we check for tuberculosis. We do controls a few times, but as a standard rule, those ones who stand it for a few months, they also stand it for a longer time. The drug survival of methotrexate is actually better than that of cyclosporine. So if I would work in this country, I would probably use methotrexate as my standard drug, as long as I do not have any problem with a young woman who wants to get pregnant. Otherwise, there is not so much to be said that needs to be done in addition. You could even combine methotrexate with a Janus kinase inhibitor. So like you do a background of methotrexate. The drug has good effect. It's not the strongest drug in atopic dermatitis, but it's a very good backbone drug, and you could add something else quickly on top, and usually what you should add on top is a topical corticosteroid, because this is easiest to do, and you need to apply only where the lesions are. So I think this is what gives background to methotrexate. Regarding Bayern München, it is the most successful football team that we have in Munich. And they have been the German masters, the first and best team now, I think, 10 years in a row. The question is not will they become the best team, but how long will it take until it is clear that they will be the best team. So they are much better in their results than all the others. But you don't need to be a fan of them, because there is many other teams that are also good. Sometimes you can also keep your thumbs pressed for teams that start on a lower point, because then you will be much more happy if they achieve getting better. And regarding the Oktoberfest, enjoy it. It will be great. And you, as younger researchers, as younger people, try to find your own field. Looking for filaggrin is a good idea, but the story is known. If it is shown for Germany and for Ireland and later on also for the US, it will probably be not that different between Madagascar and South Africa. There may be smaller differences, but if you want to make your footsteps in science, it is better to look for a new idea that has not been followed yet, if it makes sense to you. And then you will be able to publish in the very high papers as well, because people now know you and they will look at the research that is coming. So keep on working, show your energy. You are gifted, use your skills.
Thank you. Thank you, Andreas, for these amazing presentations. When I look your presentation, I need to drink beer at the fest last year. I was there, and with 1 liter cup.
Yes, 1 liter is the standard beer at Oktoberfest.
Trained by young woman with 6 bottles.
So usually if you go to the Oktoberfest, the average is that people drink 2 beers. Some do more, some do less.
It's very difficult for me. But we have an experience in using methotrexate in sclerodermia, And we have an experience with 2 ladies treated by sclerodermy for more than 3 years. And the 2 were dropped up. And after 4 months, they come pregnant. And we are worried. You don't say what to do, and you say you must stop. And they say that they must go to the gynecologist to make a checkup. She keep her baby. There are no problems. I think it's not an example. It's not an example, but it's very difficult to follow up somebody who take methotrexate, and here it's a gold standard for us in the treatment of psoriasis.
People, I agree completely. People are quite clear that you should not become pregnant while you take the drug. But there is discussions regarding the safety time after giving it, because the drug is eliminated relatively fast out of the human body, but it stays intracellularly in higher concentration. So the functional half-life is longer than the biochemical half-life. And we discussed this. There is a very nice paper on treatment of atopic dermatitis during pregnancy and breastfeeding. And we are discussing how long this should run. And just to be on the safe side, we said, first, follow your local legal requirements. Second, it may be biologically probable that the time needed after the methotrexate would be shorter. Most people now say 3 months, and some people said years ago it would be 2 years even. So this is going lower and lower. And the second thing is that there is increasing evidence that the methotrexate would not be dangerous for men willing to father a child, which also had been discussed. So nobody wants to be too much in front of the phalanx that is marching in the direction of liberalization. If you are not part with your scientific peer group, you might be chopped off when you speak too loud. That's why the entire group is marching together to say probably 3 months is enough. But read that paper. First author is Christian Westergaard from Aarhus, Denmark. And I think, Alain, you and me, we are also on that paper.
Just to say that you need highlighting this medication because it's a solution for low-income country. Because as I know, now the price of the dupilumab is around 1,800, I think. And there are many people who don't have insurance to pay for them. And I think we must do some multicentric study in using methotrexate both in psoriasis, and in atopic dermatitis, you don't know since now. Thank you.
I want to add something is because I worked for quite a long time hand-to-hand with rheumatologists because we have a mixed clinic for psoriasis, adult patients with psoriasis, and they are much more confident than us to use methotrexate. So in terms of blood testing in particular, they were doing very, very few. And so they were very confident in using methotrexate, even in more, I would say, fragile patients, like patients with rheumatoid arthritis. And they use it, as mentioned, Andreas, as baseline therapy with add-on with other drugs. So it's reduce the dosage of the other drugs and limits toxicity of other drugs. So I think the safety profile in dermatology has been viewed as with too much emphasis on toxic effects. So probably we should review our vision of methotrexate.
Good.
So I think thank you very much, Andreas. And the last paper, I think it is on the video only. It's the paper given by our colleague Professor Sarah Brown. She's Scottish, and she's one of the big experts in the field of genetics of skin barrier, and she's developed her own lab now in Edinburgh. So Sarah Brown is giving this talk, which has been recorded on genetics of AD in African people.
Thank you for the invitation to speak at this International Congress of Dermatology. I really wish I could be with you there in Madagascar, but here's my contribution. I have a short talk on the genetics of atopic dermatitis in African people. This is really some unique pathophysiology that we need to understand better. So here's an outline of what I hope to cover in the next 10 to 15 minutes. We're going to talk about filaggrin and its role in atopic dermatitis that really has been well demonstrated in many populations worldwide, although relatively little is known about people with African heritage. So we're going to focus on what is known as well as highlighting many of the unknowns. Filaggrin is named after one of its functions as a filament aggregating protein. It's in normal skin. You can see it's expressed in the keratohyalin granules in the upper epidermis. But in people that have filaggrin loss of function mutations, these granules are absent. And this is shown clinically as a common dry skin condition called ichthyosis vulgaris. People of colour can also have features very similar to ichthyosis vulgaris, but it's unclear whether this is also caused by filaggrin loss of function mutations. So filaggrin is a multifunctional protein. One of its roles is in aggregation of the intermediate keratin filaments, but it's also responsible for calcium signalling and differentiation, as well as enucleation in the stratum corneum, hydration of the outermost layers of the skin, the characteristic acidification or the acid mantle, as well as having antimicrobial properties and contributing to UVB absorption by the filaggrin breakdown products, the amino acids that are released after filaggrin is fully degraded. And it's not clear which of these functions are most important in the biology of filaggrin deficiency. They probably all play a role. So filaggrin, the protein, is encoded by the gene that's called FLG. And the filaggrin gene is located on chromosome 1 within a dense cluster of genes called the epidermal differentiation complex. And the filaggrin gene, shown here diagrammatically, is a very repetitive sequence, having 10, 11 or 12 repeats within the large third exon of the gene. The gene produces the protein profilaggrin, which is similarly repetitive, and profilaggrin is broken down into monomers, which are thought to be the functional subunits. So when you have a filaggrin null or loss of function mutation, this produces truncated profilaggrin, which is then not processed, so you end up with no functional filaggrin. When you have copy number variation, as I've said, you can have 10, 11 or 12 repeats. These have been demonstrated within the white European population. Here you can have a different number of filaggrin monomers. And work from my lab has shown that there is a dose-dependent effect on eczema risk. So if you have more filaggrin monomers, you have a relatively higher dose of filaggrin in the skin, and this is relatively protective against atopic dermatitis, although it's a much more subtle effect than the loss of function mutations that lead to effectively no filaggrin mutation. We focus on these genetic mechanisms, but actually filaggrin deficiency can occur by both genetic and non-genetic mechanisms, at least within the white European population. So we know that children with severe eczema sometimes grow up to be adults with severe lifelong eczema, and about 40 or 50% of these cases will have a filaggrin loss of function mutation. About a third also have a low filaggrin copy number. But even in the absence of genetic defects like this, it's been shown that atopic inflammation itself also reduces filaggrin protein expression within the skin. So moving away from filaggrin, we can use genome-wide association studies to look at other genetic mechanisms in atopic dermatitis. And these have been carried out mostly in white European populations, but also Chinese and Japanese populations as well. And this Manhattan plot summarises the results of a large meta-analysis that was conducted now several years ago. And you can see the highest peak, the most highly significant genetic association, is marked by filaggrin and its related gene neighbours within the epidermal differentiation complex that I've already mentioned on chromosome 1. The second highest peak we could anticipate from what we know about atopic inflammation. This includes the cytokine cluster on chromosome 5. And there are several other peaks that reflect what we know about the biology of atopic dermatitis. But we know that atopic eczema is a very diverse condition, so it's likely that the genetic mechanisms are also similarly diverse. And it's interesting to note that despite the real predominance of filaggrin null mutations in the white European population in causing the atopic eczema that we see, it appears that filaggrin null mutations in African patients are actually rather rare. So this study fully sequenced 31 South African Amakosa patients with atopic dermatitis, but no loss of function mutations were found. We also looked at tape stripped skin from the same cohort, and here about a 20% reduction in filaggrin breakdown products was demonstrated. So we conclude that filaggrin plays a rather minor role in this population, and therefore other genetic mechanisms remain to be discovered. In the second study, here again detailed sequencing using whole exome sequencing was carried out, this time for Ethiopian patients with ichthyosis vulgaris and atopic dermatitis. And again, there were no loss of function mutations in filaggrin, and actually no other recurrent loss of function mutations in any other candidate genes. So what about African American patients? Here some filaggrin null mutations have been found, but they're of a low prevalence, probably less than 1%. It's possible that filaggrin 2, a closely related gene, may play a role in contributing to persistent atopic dermatitis in this population. And quite recently, a genome-wide association study of African American patients was carried out, and this work identified a novel locus, although very near to filaggrin on chromosome 1. And this locus zoom plot shows that the most highly significant SNP is here on chromosome 1q21.3, and further work demonstrated that this is actually an expression quantitative trait locus for a gene called THEM4, or also the filaggrin antisense transcript, which is a long non-coding RNA that may control expression of filaggrin and nearby genes. So can we find out anything about other genetic risk factors for atopic dermatitis in Africa? Here again, a whole exome sequencing of Ethiopian patients. This time 22 patients found a weak association with one candidate SNP in claudin-1. So it remains to be found, the main genetic risks for atopic dermatitis remain to be found, they are currently unknown. And this brings me on to future work that I'm going to be carrying out in collaboration with Professor Rapello. He's obtained a grant to carry out this work, and I'm pleased to report that Malagasy atopic dermatitis skin biopsies and blood samples are hopefully going to be sent for analysis in my own lab in Edinburgh. And I look forward to sharing with you the findings of this research in collaboration with Professor Rapello in the near future. Thank you for listening.
We cannot congratulate Sarah because she's far away, but it's interesting to return to this question we discussed partially yesterday at the meeting with WHO. What is the mystery of skin barrier dysfunction in people with like skin who develop atopic dermatitis? Because the agreement that there should be also a skin barrier defect, maybe acquired if not genetic, but if it is genetic, it's probably something which modulates the skin barrier and which is different from what has been investigated so far, because even the claudin deficiency is not probably enough to make a statement that we have found something in sub-Saharan black skin patients. So I hope that your investigation will at least show us that maybe there are some Asian genes with Asian mutations in patients from Malagasy origin that may correspond to the question. But one point was said and mentioned to Professor Schmidt. So, what is the equivalent of ichthyosis vulgaris in patients seen in sub-Saharan Africa? Because by definition, we know that ichthyosis vulgaris is caused by a mutation in filaggrin. And this is well established. It's not just an association like in atopic dermatitis. It is the causation of the disease. So what we have some colleagues from Africa. What is your opinion about what is the equivalent of ichthyosis vulgaris in your population? Nobody knows what is the equivalent. I think this is the question, because you said many patients have dry skin, but not dry skin and atopic dermatitis.
You mean the clinical presentation? Yeah. So ichthyosis vulgaris is, a quite common findings in Black Africans. Sometimes they do have dry skin on the leg, extensor part of the leg, and the dry skin is not usually abused, but the most common presentation is on the dry skin on extensor part of the leg. The lower leg. Yes, hyperlinearity is also seen, but it's less common than dry skin on a lower part of the lower limb.
Did you investigate X-linked ichthyosis in your population? No. Because my experience is that X-linked ichthyosis is not uncommon in black skin patients. So I think we know this disease in black skin patients, but we still don't know the equivalent of ichthyosis vulgaris. So, but we know that in patients with X-linked ichthyosis, having simultaneous filaggrin deficiency increase the phenotype. It has been well shown by the group of Heiko Traupe in Germany. So I think maybe there is something also in the genetics of African black skin which maybe increase also the phenotype of X-linked ichthyosis. But we still don't know what it is, and it's maybe completely different, but affecting the metabolism, indirectly the metabolism of filaggrin.
Our problem in this study is to find some control patients, because we want to do well exam study, but to find control, normal control, is very difficult, because as I said to you, here you are in winter, and you say that Andrea said to me that it's the first time, you know, that in tropical we have it's cold, and we are in a hill here in the middle of Madagascar. And our problem with Sarah is to find control patients. And it's known that ichthyosis vulgaris have a link with the mutation of filaggrin, but the border of these two diseases is very difficult to show. And when you study, as I say, as she saw, when I study, there are no cases who can give you a result to compare. That is a big problem. And when you start to study genetics in black skin, you have many problems. Even to send sample from Madagascar to Edinburgh, after 6 months, no solutions. No solutions. And it's the way that I wrote to Peter to say that do you have an example, a sample for with black skin to compare our study, because we can do it. Mandrant is not there. That is not there, because we can do the extraction, we can do amplification, but the problem is some.
Okay. Also, a lot of efforts first to go through ethics, about almost a year, and of course the hard work is done by our colleagues in Tanzania to convince people. But for controls, that's also not that easy in Switzerland, especially if you ask for skin biopsy, then you need good arguments. But it's hard work, I agree, and maybe here the limits are much higher. But the credits go to our team in Tanzania.
But I think we also discussed with some colleagues this issue of what is really the problem in stratum corneum in black skin. But probably we discussed this morning proteomics in the diagnosis of fungi. But proteomics now is widely used in labs as well as metabolomics. And you can use proteomics from tape stripping, for example. And I think it can provide you a lot of information, and something you cannot, of course, predict before, because then we are going to filaggrin, but it's very focused. And if you go to proteomics, you have a neutral approach, and you may find something. I think it's better to, in my opinion, to go directly to tape stripping and proteomics, and have the good groups, the patients, of course, maybe some dry skin patient, you don't know if they have atopic dermatitis, and of course normal patients, normal control, sorry. So I think it's time maybe to finish, yes. And we had a very interesting session. Thank you very much, Benja, my co-chair, as well as Peter. And I think we have, some enthusiastic perspective looking at more research in sub-Saharan Africa, including Madagascar. Thank you to you all for your intervention. And what is the program?
Thank you, and thank you all of the speakers. You highlight this disease in Africa, especially in Madagascar. I think although the medical doctor, not dermatologists or dermatologists present here, have enjoyed it. Professor Lal said to me, we don't know Andreas, and when she see your presentation, she said, oh, it's very important for me. High level. Thank you. And thank you for brother from Mali, from Mauritania, from Tanzania who live today. Thank you very much to join us in this 70th Congress of Madagascar. The board of ISAD stays till Saturday, and in Madagascar you say Veluma. Veluma, it's goodbye. I think you enjoy your stay in Madagascar. During the exposition of laboratory, we have some products from Madagascar. I think you enjoy it. You can buy something like essential oil. It's very important. We have many kind of essential oil here. Thank you very much. Thank you for all of us who stay. Next time maybe we come. Thank you. Applause.